We're going to get started with our next session this morning as we move up the GYN track to talk about endometrial issues. I'd like to introduce Michelle Davis, who's, again, one of our partners in the Division of GYN Oncology. She's, I think, got the coolest title of any talk today. It's kind of neat. I like it. But she's going to talk to us about endometrial neoplasia and cancers. And I'd like to introduce Michelle. You want to come up? Slide advance.
Forward and pointer. All right, great. Thank you all so much for the opportunity to speak today. I did not choose my title, but I also like it, and I think important in a cancer that is on the rise. I have no disclosures. So I always want to start with statistics, and as I update this talk every year, I think probably what's most astounding is that each year, both the incidence and mortality for endometrial cancer is rising. So from the 2024 statistics, there are over 67,000 new cases of endometrial cancer in the US each year, and the mortality has officially passed ovarian cancer as now 5%, accounting for all female cancer-related deaths. Overall, the lifetime risk is still about 2.5%, and while most cases are still found early and can be cured with surgery, we are seeing this rising incidence, and in particular among young women. So that is rising both among women in the 20 to 29 age group as well as the 30 to 39 age group, over 1% per year. It's disproportionately rising among Black women, 2 to 3% per year, and up to 5% for some of the high-risk histologies. And as I mentioned, it has a higher rate of mortality. And I've had this slide up before, but it basically demonstrates the rising incidence across all countries. The rate of rise is highest among developing nations or developed nations, mostly correlating to the rise in obesity, but across the board globally, the incidence is rising, and in 2040 is expected to have increased by over 50%. And so what are the risk factors? Why is it increasing? The biggest risk factor, as we know, is excess estrogen exposure. And while we have classically thought of this as a disease in postmenopausal women, average age of 60, again, much younger women are being found. And so it's really important as gynecologists that our threshold for evaluation is lower. There are genetic predispositions. About 5 to 10% of endometrial cancers are going to be genetically related. Most commonly is going to be Lynch syndrome. And the lifetime risk does vary depending on the type of mutation, as well as the sort of lesser-known Cowden syndrome with a lifetime risk up to 20%. So we'll talk about it on the next slide, but it is really important to get a good family history and consider genetic testing for some of these patients. And obesity, probably the single biggest driver of endometrial cancer risk. For every 5 kilograms per meter squared increase in BMI, there's a 60% increase in risk. And just to sort of correlate, when we talk about things like tamoxifen use, people have about a 2 to 3-fold increased risk. A BMI of 30 is the same as that, which in the US, unfortunately, is about 2/3 of the population. When you hit a BMI of 40, there's a 7-fold increased risk of endometrial cancer. And then there's the other factor of our high-risk subtype. So serous endometrial cancer is also on the rise. This is the more aggressive subtype with higher risk both for extrauterine disease at presentation as well as for recurrence. It's about 5% per year now, especially in Black women, and we don't fully understand why. And so I want to take a minute to talk about cancer prevention because I think this is where, as general OBGYNs, we can really make a difference. And I think step one is patient education. There's pretty good data that a lot of women, especially Black women, are not aware of the risk factor of postmenopausal bleeding. And so something as simple at your annual visits as talking about if you have any abnormal bleeding or if you have any bleeding after menopause that is abnormal, to making sure that people are getting in quickly if they have those symptoms. Weight loss, as I talked about, is vitally important. And again, there is this phase where people have completed their fertility but are not yet in menopause, where I think we have an excellent opportunity to talk to people about weight loss. And as the ability to manage weight with medical management and GLP-1s is evolving, I think we have a great opportunity to potentially change the risk for a lot of women. And then looking at abnormal bleeding really seriously. So I've included this sort of classic palm coin diagram looking at both hormonal and structural causes of abnormal bleeding. But I think as the rates of both precancer and cancer in young women increase, again, the threshold for evaluating abnormal bleeding needs to be a little bit lower. And so I will find in my personal practice, I'm seeing a lot of women, even normal weight, in their 40s to 50s, who have had abnormal bleeding for a couple years and ultimately have EIN or cancer. So I think, again, the threshold for biopsy just needs to be lower. And then thinking about that family history, because there is a role for risk-reducing surgery for these women. And for young women who are aware of a Lynch diagnosis, we actually do follow them with surveillance endometrial biopsies until they would consider a preventive hysterectomy. And it's a little hard to read, but you'll see it for your slide packets. These are two of the sort of classic guidelines for when to send or evaluate genetic testing. If you have access to a genetic counselor, they are also a great resource. If someone has a strong family history, GYN or colon in particular, that they can be seen by your genetic colleagues. So when we talk about pathology for endometrial cancer, we classically thought of it in two buckets, sort of a low-grade estrogen-driven cancer, which accounted for about 2/3 of cases, generally very good prognosis, and then a high grade, about 1/3 of cases, generally worse prognosis, often need additional therapy. But as we understand more about these tumors, in particular the molecular classifications, that is changing. And a study published now probably close to 10 years ago from the Cancer Genome Atlas actually reclassified endometrial cancers into 4 different subtypes. And these are actually very important prognostically, and they are sort of the way of the future of how we're going to look at these cancers and how we're going to tailor treatment. And so just for awareness, these are sort of the 4 classifications. The first is MMR deficient. So this would include someone who has Lynch syndrome. These are the mutations in Lynch. But about 25% of endometrial cancers will have an abnormality in mismatch repair proteins, which is important because they might be candidates for novel therapies like immunotherapy. P53 mutant is typically associated with those high-risk subtypes like serous cancer, but there are many cancers that you would classically not think of as high risk, grade 1, stage 1, that actually have a P53 abnormality, and it significantly impacts their prognosis, and these are the people that maybe those early stages that are recurring that we didn't know why before. And then the last group that we talk about is POLE, which is an ultra-mutated type of cancer, which actually they do very well. So even women who have maybe stage 3 or even stage 4 with a POLE mutation, we're finding are not recurring as much. And I'm going to show you the next slide to demonstrate that. So there may be a role for pulling back therapy, pulling back chemotherapy in them. And so this is really the focus of ongoing endometrial cancer research. And this is just sort of a visual demonstration of how we look at these classifications. Most of them can be done with your pathologist through immunohistochemistry staining, in particular P53 and MMR, which we are doing universally at our center. But again, every center is still a little bit different in taking this up now. But probably the most important thing here is these survival curves. And you can see that blue line, POLE, P53 wild type, these patients do very well, which is sort of classically what we think of. But that very stark difference with our P53 mutant cancers. And again, not only serous, you're seeing these in low-grade endometrioids too. So understanding how to treat them differently. And all of these ongoing trials, which haven't resulted yet, the hope is by tailoring therapy, we might be able to close some of those gaps. And so because of this molecular classification, it has changed our staging. It's a complicated slide, and it's complicated for us. And I would say that's probably the take-home, is that it's gotten more complicated. But the goal of it is basically based on some of these features that make someone high risk to translate that into prognosis. Now, we don't totally know what to do with it all yet. We're not necessarily changing our practice until those studies are published. But just to say things like extensive lymphatic involvement or high-grade histologies are actually now upstaging patients, which would have been a stage 1 before. And so I want to shift gears and focus on a couple cases and demonstrate how we treat endometrial neoplasias through our patients. So the first patient is a very typical patient we would see in the office. She's a 58-year-old postmenopausal. Her BMI is 53, and she presented with postmenopausal bleeding. That's her ultrasound you can see in the background with a thickened endometrium of 1.7 centimeters. She has associated comorbidities, hypertension, diabetes, and had a biopsy consistent with a grade 1 endometrioid type cancer. So what are her treatment options? So classic treatment for endometrial cancer is going to be surgery with hysterectomy. There are a subset of women who may not be a candidate for surgery based on their medical comorbidities. And again, as rates of obesity are rising, we will do a lot of robotic surgery on women, even into BMIs in the 60s and 65. But really, once you get over 65, you're sort of pushing the ability of what you're able to do robotically, in particular with Trendelenburg positioning and with insufflation. And so there are other options that they can be treated with, either definitive radiation therapy or hormonal therapy more as a bridge potentially to surgery down the road. There are also patients that we see who are, in their late 80s and dementia and have other things going on. So you think about, more temporizing measures, but surgery still is the mainstay. And for your non-endometrioid high-risk subtypes, really, if you're not able to get them to surgery, you're talking about more chemotherapy, and it's just because the risk of distant metastasis is much higher. And so starting from the beginning, you're going to get a pelvic ultrasound, and I think these are questions that often come up at this course is that, what are our thresholds based on the ultrasound to think about doing a biopsy? So classically, 4 millimeters had been considered abnormal based on ACOG guidelines for a postmenopausal patient. And there's an asterisk by it because data has suggested that probably the sensitivity of 4 millimeters is not as good as we thought. 3 millimeters has a sensitivity of probably about 98%, so that is reasonable. But there was data that was published by Kemi Dahl looking at, in particular, in Black women and the thickness of the endometrium. And because of things like fibroids that can distort the cavity, we are probably under-evaluating and potentially not seeing abnormalities based on thickness alone. And so the sort of take-home is really any postmenopausal bleeding probably warrants a biopsy. There are some women who have clear atrophy in a 1 millimeter endometrium, and that's someone you can probably just watch and repeat. But in general, biopsy should really be your next step. What about someone who has no symptoms and just comes to you because there's a thickening on the endometrium? Typically 11 millimeters is about the threshold where the risk starts to become higher for endometrial cancer. The risk can be up to 7%. And there's some data that's published that anything over 8 millimeters, even in a premenopausal patient, depending on where she is in her cycle, can be associated with some type of pathology. So not cancer, but a polyp or hyperplasia, and so probably we should be thinking about evaluation. MRI has a really limited role if we're thinking about not operating on someone for fertility-sparing purposes, which we'll talk about more later. The MRI gives a much clearer view of the endomyometrial junction, but in just a routine endometrial cancer, typically the ultrasound is all that you need. And then if someone comes back on a biopsy with a high-grade histology, so serous in particular, but grade 3 clear cell, we do CT scans of the chest, abdomen, and pelvis because they have about a 30% risk of having some type of cancer outside of the uterus at the time of diagnosis. So that can be very helpful for us to have that information already. And then sampling can happen however it makes sense for you. Endometrial biopsy works perfectly. Gold standard technically is still a DNC because there are studies that show you are actually going to get a more accurate biopsy. And in particular, if you have EIN on a DNC versus EIN on a Pipel, more likely that's going to correlate on the final hysterectomy. So DNC is a little better, but you don't have to do that. There's been questions before about, does MyoSure hysteroscopy affect staging, and is that going to worsen prognosis? And the answer is no. There's retrospective data, but that shows that there's no increase upstaging, abnormal cytology, or lymphovascular space invasion, which is probably what matters the most, no matter the route of sampling. So it's really whatever is your preferred sampling is just fine. And we'll talk about hysteroscopic resection for fertility sparing in a little bit. And then the last thing is that if there really is a discordance between what you're seeing on the ultrasound and what you're getting on your biopsy, you're getting scant inactive endometrium, but it looks abnormal, resample. Trust your instincts, trust the imaging that there probably is something more there. And so we talked about surgical treatment being hysterectomy. It usually will include removal of the tubes and ovaries. Pelvic washings are no longer a part of surgical staging, though they may have prognostic significance for women with high-grade histology, so we sometimes do still collect them. And then some type of nodal evaluation. And I would say at this point, sentinel lymph node evaluation is pretty much the standard. And then if someone, again, has a high-grade lesion, we're going to do some extra biopsies. And this is just pictures of how we do the sentinel lymph node technique. We inject the cervix at 3 and 9 with indocyanine green dye. It gets taken up in the local lymphatics, and then with an infrared camera, we're able to actually highlight the nodes. And so you can see an obturator and an iliac node here that we can remove in isolation. The sensitivity and specificity are very good. Negative predictive value like 99% with low false negative rates. Very comparable to breast cancer on like really large scale studies. So even for high grade lesions, this really is sort of our standard at this point. And you can really use any approach, but minimally invasive surgery still is the mainstay, especially when you're talking about women with obesity, either via conventional laparoscopy or robotic surgery. We sort of limit laparotomy to very large uteruses. We try to avoid we don't do any morcellation, but we recommend avoiding morcellation if at all possible. And there can be a role for vaginal hysterectomy. So there are patients that I've had who have significant pulmonary disease and like really just can't tolerate that positioning. And we forego nodal sampling and actually do a vaginal hysterectomy to basically just be able to get the uterus out. So you sort of weigh the risks and benefits there. So all really have a role here. And only because the data in cervix has changed, this is just the original data from endometrial cancer to show that laparoscopic surgery is safe and effective with no difference in cancer-related outcomes, and these are now over 10 years out, so 10-year long-term overall survival outcomes to say that laparoscopic surgery is safe here. There's been questions about the role of intrauterine manipulators in retrospective studies. That is still sort of ongoing. At this point, our practice is still very much to continue with minimally invasive surgery. And so as we talk about what is good quality effective care in uterine cancer, research groups have sort of come up with a couple of different criteria to make sure that across the board we're providing equitable care to the women we take care of. And so one of those is timely referral to surgery within 6 weeks. Now this is usually from seeing us as GYN oncologists to getting to the OR, not from the biopsy to the OR. Utilizing minimally invasive techniques and nodal sampling, and then making sure patients get adjuvant therapy when they need it, radiation or chemo. And so in a very large national center database study looking at over 300,000 women, they looked at were Black women getting the same care as white women? And unfortunately, what that study showed was that they were not. They were 16% less likely to receive sort of perfect care. But I think probably more disturbing in this is that even when they did, in those early stage cancers, Black women were more likely to have increased 30-day, 90-day, and 5-year mortality. And so this is a really important area of ongoing research in making sure that we are providing equitable care for our patients. After their treatment, they're ultimately going to be followed in surveillance. And the bottom is the sort of classic NCCN recommendations, which is pretty much the same for every type of cancer. Exams every 3 months for 2 years, and every 6 months, and then once a year. In 2017, the SGO published an updated guidance on following low versus high-risk women. And the reason is there's actually some nomograms that you can use to say what is the 5-year risk of recurrence. And there's some women where it's 2 to 3%. So by sort of scaling back surveillance for those patients, that can minimize some, surveillance-related anxiety. And so for low-risk patients, 6 months in the first year, totally appropriate. They can go up to annually after that and are very appropriate to be followed by a generalist going forward, which really is going to be just an exam, a good review of systems, and biopsy as needed. Pap smears no longer are part of routine surveillance. The data was that most cancers are going to be found based on physical exam alone. You get a lot of false positives with a pap smear, especially if someone's had radiation. You get a lot of extra biopsies and things. So no pap smears. The only time I use it is if someone comes in with bleeding. There's nothing visible on their exam. I'll use it sort of in a diagnostic way. CA-125 and imaging is not necessary and isn't part of routine surveillance, though if someone got chemotherapy or had advanced stage disease to start with, we often will follow with those as well. But again, very appropriate, especially for the low-risk patients, to be followed with routine exams after that first year. So we're going to shift gears as we move on to our second patient. She is a 45-year-old premenopausal patient who came in with abnormal uterine bleeding. Her BMI is 29, and I included her because she is a patient that I am seeing more and more, and someone you might not necessarily be biopsying just based on that history alone. She ultimately had a DNC, and pathology came back as EIN, or endometrial intraepithelial neoplasia. So I want to take a minute to talk about the pathologic characteristics of uterine precancer. And the sort of classic is the WHO criteria, which is based on two things: glandular complexity and nuclear atypia. And so this has been well established. It's been around for I don't even know how long. But the downside is, as many of you may be aware, is that with the subsets of simple hyperplasia, complex hyperplasia without atypia, complex atypical hyperplasia, there's a lot of subjectivity. And if you actually have two pathologists look at the same slide, the agreement is like under 40%. So there's a lot of variability, and the concern is that we may be missing something. And so an international endometrial collaborative of pathologists basically now in 2005 came up with criteria that uses basically more criteria to better try to see what's a true precancer. And that's what EIN is from. And so these are the criteria that they utilize to define it. And what they found in those initial studies is that the agreement between pathologists was much higher, so 75% concordance when looking at it, and they were much better at predicting cancers. It's not universal, so not every center does that, and that's probably the major limitation. But I think what's most striking from their initial papers was that when people were classified based on their normal WHO score classification, when they're reclassified with the EIN criteria, many of those are changing, and atypical hyperplasia as you'd expect, but complex non-atypical hyperplasia, and then even 4% of simple hyperplasia is being reclassified as EIN, and they found cancers in all of those patients. And so they're, while small, maybe a subset of patients that we're missing, and so just to advocate that this EIN schema hopefully has improved diagnostic accuracy for all of us. And so how do we treat EIN? So EIN is a precancer, and so we do think of definitive therapy as surgery with hysterectomy, though again, as women become younger, treatments are varying, and we'll talk about that with our next case. There is a question about who should be doing those surgeries. Can these be done by general gynecologists? Do you need a GYN oncologist? And there's pretty good data to show that it is very appropriate as a general gynecologist to do these cases, but there is a risk, about 30 to 40%, that at the time of final hysterectomy, we will see an endometrial cancer. Not all of those need lymph node staging, but some of them do. And the thicker the uterine lining is, especially once you get over 2 centimeters, the risk of there potentially being a cancer that might need lymph node staging is higher, up to 40%. So those are the ones that you might think more preferentially should be referred. As GYN oncologists, some of us do sentinel lymph nodes on all EIN cases. Some of us wait and send frozen and then decide. There's not really a right answer there, but just to say that there is definitely a percentage of these patients who will need lymph node sampling and benefit from that. So just to keep that in mind as you take care of them. And then it brings us to the ovaries. So again, as we are taking care of a younger patient population, there is data that was published showing that for women who have their ovaries out for benign reasons under the age of 50, they're at a higher risk of dying of all-cause mortality, basically up to age 50. It's more pronounced under 45. It's even more pronounced under 40. And so there's very much benefit to keeping our ovaries in place in young women. After 50, probably less so, is what the data shows us. So it's a really important discussion to be having with your patients in clinic. If there's a cancer, there is a small risk for ovarian metastasis, depending on what you read, can be 5 to 8%. So these sometimes can be sort of nuanced discussions about what to do depending on what you find, but all to say, you can always come back with laparoscopic surgery. If you do a simple hysterectomy and then it comes back as cancer, you can always come back for those ovaries down the road. So that's some of the discussions we have in clinic. So finally, we'll move on to our last patient. She is an even younger 32-year-old G0. Her BMI is 40, and she presents with abnormal cycles during a fertility workup. She also has PCOS in addition to her obesity. She has a hysterosalpingogram that shows a polyp, and then she has that polyp removed, which shows a grade 1 endometrioid type cancer arising in EIN. And she very much desires fertility preservation. And so as I sort of talked about earlier, there are non-surgical options. While the standard is still surgery, there are patients in whom you can consider fertility sparing or non-surgical management. The bottom is those medically inoperable patients, which is generally a small percent of who we take care of. Definitive therapy is radiation, and with radiation nowadays, you can get cure rates over 90%. So someone who really has a lot of medical comorbidities, that's usually my first choice. In those patients, we think about medical management. I think about it really as a temporary measure, or for someone who has so many other comorbidities that those are going to be more of a problem for them than this, because response rates are probably in the 50 to 70% range. But for young women who desire fertility, really the only option for treatment is going to be hormonal therapy. And again, these numbers are rising on who we're taking care of, and so we're seeing this more and more. This table comes from the NCCN guidelines, sort of who you would consider for fertility-sparing management. And first and foremost, these need to be early low-grade cancers. Our guidelines say grade 1, and typically less than 50% or no invasion into the uterine muscle at all. So this is where an MRI is helpful. Ultrasound's really not going to show you that, and so getting an MRI for these patients, also to rule out lymph node metastasis, to look at the ovaries really well, is usually my first step when I see them in clinic. You want to have a really good sampling. These say ideally a DNC, and you want to have an expert pathologist look at it, because again, there is a risk that you could upstage that cancer, or if it's EIN, it may actually be a cancer in the end. Usually we recommend some type of consultation with a fertility specialist, potentially a geneticist, especially with a young age of diagnosis. And then if they meet all those criteria, then we can treat them with hormonal therapy, which we'll talk about in a little bit more detail, but either oral or an IUD. And then you're going to sample them. Sampling can be anywhere between every 3 to 6 months. Generally, I tend to sample on the shorter side, closer to 3 months, and that's just because a lot of these patients are in their late 30s. They're very much looking forward to moving forward with pregnancy as soon as possible, and so the idea is just getting them there quicker. The downside of doing that is that there is more sampling and there can be risk for things like Asherman syndrome, so it's always a discussion with your patient. But I would say I generally err on the side of more frequent biopsies. You want to see at least 2 negative biopsies to consider clearance by your pathologist, and our pathologists usually want them off progesterone for a series of weeks before we do the biopsy. Not all pathologists feel that way, but the progesterone effect can make it harder for them to evaluate the glands, and so usually we'll do a period of a washout somewhere between 2 to 4 weeks before resampling, and I again tend to resample with a DNC just because making sure we're not missing anything. Once they clear, if they clear, we then encourage them to get pregnant as soon as possible. Post-pregnancy, we usually talk about placing an IUD then, sort of in the interim. I often will biopsy people or have them get biopsied once a year, sort of in between pregnancies, just to make sure there's nothing that's changing. And then once they're done having kids, completion hysterectomy is still the standard management. So they got to be early and they have to be well counseled. So these are the therapies. And the caveat to this slide is that there's not one right therapy. All of this data is based on observational studies. Most of them are hundreds of patients, though there are meta-analyses now that are giving us much bigger samples. But just to say, the data going in is all observational studies, no big RCTs here. The oral agents that you can use are medroxyprogesterone or Provera or megestrol acetate, but these are much higher doses than you would use for simple hyperplasia. So you're talking about 600 milligrams daily for Provera or Megace of 160 to 320. And usually my preference is to go with Megace, just partly because the dosing is easier for patients. And I usually start with 80 twice a day, but ramp up pretty quickly depending on what their response is. As you can imagine, these high-dose progesterones have side effects, weight gain, headache, breast tenderness, very small risk for VTE. So in a population who's already at risk for those things, you want to be thoughtful about using these pretty high-dose progesterones. Continuous is better than cyclic. So again, unlike simple hyperplasia, you want to be on continuous progesterones here. And regression rates have been reported, and this is both EIN and cancer, somewhere in the 75 to 85%. Complete responses closer to 55%. The reason completion hysterectomy is recommended is that for all of these, relapse rates are somewhere between 25 to 40%. So they can progress, and these lesions can come back. The IUD, the benefit is that it goes in the office. You can replace it when you resample. Patients really have minimal symptoms. They usually are amenorrheic in this scenario, but they might have a little bit of spotting is probably the biggest complaint. And regression rates are reported similar and actually even a little bit higher in observational studies, up to about 90%. And then there are studies looking at combination. And again, in combination, potentially the highest rate, but these are all sort of minimal observational studies. And then going forward, there are ongoing studies looking at the addition of some other agents, metformin. How may that play a role, especially in a PCO patient, but for everyone, can that be beneficial? And then looking at some of the new GLP-1 inhibitors, how does that play a role? So we don't have the data for any of this yet, but just to say these are ongoing areas of interest and study. And so probably the newest guidelines that have been published on fertility-sparing management came from the European Society. And so these are the ESGO guidelines from 2023. And just to highlight the very first thing that they say, that there are 0 studies based on level 1 evidence. So really, we are still limited in how we're making this guidance. It's a lot of expert opinion. It's a lot of observational studies. But they recommend a good pathologic review. They suggest there may be a role for expanding even to grade 2 cancers, so being a little bit more liberal in who we're choosing. There are patients I've taken care of who have grade 2 cancers who are being medically managed, so just to say with appropriate counseling, it is possible. They recommend hysteroscopic sampling for diagnostic accuracy, and there are actually a lot of studies globally that are looking at hysteroscopic resection as a part of treatment. So by actually going in and fully resecting the cancer, at least in those very small case series, the clearance rates are as good or potentially a little higher. So there may be a role for doing a little bit more hysteroscopically. And then managing either with an IUD or an oral progesterone. As I mentioned, 2 consecutive biopsies to consider clearance. In my practice for EIN, I typically manage patients with the Mirena IUD unless they feel strongly otherwise. It's easier, patients tolerate it well, clearance rates up to about 90%. For cancer, typically I will do a combination, so I'll do both an IUD as well as the Megace. Not everyone wants to do it. You can do just an IUD alone, but the thought process is that for these patients, it is a little harder to clear. The complete pathologic response rates in most studies is like 50 to 60%. And so I try to maximize what I'm using earlier on, because again, most of these patients are late 30s and the time window does matter. And so what about weight loss? So probably the best level evidence we have, which came from a randomized control trial a couple years ago called the FEM trial, which looked at an IUD alone. This is all in cancer patients, not EIN. IUD plus weight loss, or IUD plus metformin. And ultimately, it was a negative study. They all performed about the same. Everyone in every group lost some weight, but ultimately showed, again, a complete pathologic response rate of probably about 60%. So I think the most important takeaway from that is that the IUD is effective, and you can probably counsel people about a 60%. But in a different trial, when women lost more than 10% of their body weight, which is more weight than they lost in the FEM trial, it did increase the response to progesterone by about 4-folds. But it's really hard to lose 10% of your body weight on your own. In that same trial, only about a quarter of women were able to do it on their own with calorie restriction. But with the addition of bariatric surgery, almost 90% of them were able to get to that weight loss goal. There are studies ongoing at Brigham and Women's led by Dr. Feltmate looking at combination bariatric surgery with hysterectomy for endometrial cancer. And I'd say from a purely effective weight loss standpoint, that probably is the most effective. But this is where data on GLP-1s I think is going to be so important, because patients really can lose a lot of weight medically this way. They're certainly more receptive to it. And again, that 10% threshold is pretty high and hard to do on their own without some additional help. And we talked about sampling, again, every 3 to 6 months. You want to make sure there are negative biopsies, mostly because of that regression rate. And then once cleared, they can proceed with pregnancy. Most of the data shows that if it's going to work, it's going to work within about 9 months. So 9 to 12 months, you're going to see the vast majority of regression. If you haven't seen clearance by 12 months, probably it's not going to clear. I have managed people beyond that, and I think with appropriate counseling, they certainly can. I have had patients who at 2 years cleared, so not everyone follows exactly in this paradigm, so every visit is a really important counseling discussion. But in general, most people are going to clear within the first year if they're going to clear. And then as we talked about, in the end, hysterectomy is the sort of definitive treatment. As molecular data plays a role, how much does that play a role in these patients? Should we be medically managing someone who has a p53 abnormal low-grade cancer? We don't know. Makes me uncomfortable. So lots for us to sort of think about as we go forward. But I'd say takeaways in that yellow that we don't have an optimal route or dose at this point, and so these therapies still need to be standardized. And so for our take-home points, risk factors for endometrial cancer, still the mainstay is excess estrogen, obesity. Obesity is rising, and that is absolutely correlating with the rise in endometrial cancer rates and also correlating with a decrease in age of diagnosis. And so we just have to be more thoughtful about the patients we see in clinic and biopsying early. Genetics does play a role, so making sure we're taking good family histories and referring as needed because some of these patients may benefit from preventative type procedures. The mortality, as I mentioned, is rising. It's disproportionately rising in Black women and is absolutely an area of ongoing investigation that we need to close that gap in equity in care. We talked about the molecular characteristics and how that's going to be important going forward and might actually change the paradigm of how we treat people after surgery. Minimally invasive surgery still is the mainstay in how we take care of our patients, but there are alternatives if someone is looking for a fertility-sparing approach or really are medically inoperable. And weight loss is a part of this. It's hard to do in clinic, and we're all really busy. And, when I first started doing this, I felt like patients don't want to hear about it. But every time I've talked to patients about obesity is a risk factor and these are the options, in the end, they are thankful to have those options and that someone talked to them about it. And in a world that's evolving with medical therapy, it's really important that we talk to our patients about this. So that's all I have, and happy to answer any questions.
Michelle, that's a fantastic talk. I always learn something from you every time I hear you give that talk. Are there any questions? Mike? Yeah.
For abnormal uterine bleeding, do you have an age at which you always biopsy them, or do you do it always after a certain age, but under that age they have risk factors?
Yeah, so ACOG says 35. I struggle now because I have many patients in my practice who are in their 20s. So I would say certainly if they have risk factors, obesity being the biggest one, I would say one risk factor at any age I probably would biopsy.
There were a couple questions that came in through the chat about how you evaluate women who have had prior endometrial ablations. Mm-hmm. And what do you use as a cutoff on an ultrasound, or how do you biopsy those patients?
Yeah, it can be very difficult. So, with an ablation, I think the ultrasound probably is not helpful or reliable at that point, and oftentimes the sonographers will say so. I think if you're able to get a biopsy, however you can do that, with an office pipelle, with a DNC, fabulous. Sometimes you can't. So there are scenarios where I've had patients who've had ablations, they've had recurrent bleeding, we're not able to sample them, and we talk about hysterectomy just because there's not options. But I'd say sample however you can. Try in the office first, and then if you need to go to the OR.
And then sticking with the ultrasound findings, one that I think comes up a lot in practice is the patient who has fluid in the cavity on the ultrasound. Mm-hmm. Maybe the stripe's a little thick, maybe it's not. Do you worry about that? Do you sample those patients? How do you manage the fluid in the cavity situation?
Yeah. So also really common, and I would say depending on, ultrasound is very subjective. So depending on the sonographer, some count the whole thing with the fluid as a thickness. I'd say a lot of sonographers can actually distinguish the lining from the fluid. So if the lining is thin and there's fluid, I think you can be reassured that the lining is thin and you don't have to sample. The assumption is that there's cervical stenosis, and again, there might be something more there going on. I would say my threshold to biopsy is very low, and if you can safely do it, easily do it, I think that's reasonable. But you can be reassured by a thin stripe with fluid in the cavity.
Do you take those patients to the operating room for a DNC? Since, if it's cervical stenosis, so that's why they have fluid there, and you can't do an office biopsy, are you concerned enough to take them to the OR for
A DNC.
Yeah.
Yeah, I don't know that I would necessarily go straight to a DNC. I think it depends on their bleeding patterns and their other risk factors. But if you can't get it in the office and you are concerned enough, either by recurrent bleeding or risk factors, I would.
Another question that I think came up when you talk about negative biopsies or for patients you're managing hormonally. Between those biopsies, are they still on hormones? Or when you say consecutive biopsies are negative, that mean you've cleared it, you take them off hormones, and you repeat it, and they're still negative? Or are they continued on therapy through that?
Oh, yep, sorry, yeah. So they stay on hormones. So basically, they will be on whatever their management is, say it's the IUD. And say we sample them at 3 months, we remove the IUD in advance of the biopsy, we resample, that biopsy comes back clear. I always, if I'm doing a DNC, I always replace the IUD at the time of the DNC because we can always take it out, but then they basically would keep that in for the next 3 months, and then we need one more sample with clearance to then take it out for good.
And could you speak a little bit more about the risk of tamoxifen and on endometrial pathology and how those patients should be managed or surveyed?
Yeah. So the risk with tamoxifen is about 2 to 3 folds over the general population, which, as I mentioned, is the same as someone with a BMI of 30. And so we don't actually recommend doing anything extra for them. Sometimes their breast oncologist will order ultrasounds, and it can be tricky because you get these sort of cystic spaces, subendometrial cystic spaces, and then that's more difficult to follow. But in general, we don't recommend doing anything different for patients on tamoxifen, except if they have postmenopausal bleeding, and then we'd sample. In the same way that your BMI of 30 patient, you're not going to be following with ultrasounds.
Have you been able to biopsy patients with IUD in place, or do you always remove it and then do your sampling?
Yeah, so you absolutely can, and a lot of people do that. So they just leave the IUD in and they do an office biopsy, completely appropriate. Our pathologist in particular, I think, feel strongly that that progesterone effect limits their ability to fully evaluate it, which is why we do what we do. But if your pathologist is able to get you a clear reading, you can leave it in, do it all in the office, which is obviously nicer for patients from a procedural perspective.
And then another question about patients with the IN who you're operating on and trying to decide whether you do nodes or not do nodes. What do you do in your practice? I know you said some in our group do, some don't. Just so where you come down and how you decide what to do.
Yeah. So what I came down on is basically I inject for the sentinel node so that I can find it. So I identify where they are, and then I send a frozen section. It takes a little bit more time, but I would say most of the time we don't have to remove the nodes. So I think, complications happen for all different reasons, and it's not worth it to me to universally take out the nodes unless we really need to. So that's what I do.
Gotcha. Well, great. Are there any other questions from the floor? Well, again, thank you so much, Michelle, for a great lecture. And again, there'll be a panel discussion in just a little bit. So if there are other questions that come up, we can address it then. So.
Thank you.